Welcome to this episode of CRST the podcast. In today's program, Professor Stefano Barabino, Professor of Ophthalmology and Head of the Ocular Surface Center at the Sacco Hospital in Milan, Italy, will lead the first of three discussions focusing on dry eye disease, or DED. In this episode, we'll share the history of how dry eye was determined to be a disease rather than just a symptom, and what is happening at the ocular surface in the vicious cycle of DED. We'll also discuss the disconnect between signs and symptoms in this condition, the link between cataract surgery and DED, and the increasing prevalence of DED in younger people associated with increased use of screens.
Today we are talking about dry eye. Dry eye is a very important disease. We see a lot of patients with this disease. So it is probably time to understand something more about the disease, something more about our patients. I would like to welcome Professor Maurizio Rolando. Maurizio is a professor of ophthalmology at the University of Genoa, Italy, and Professor Preeya Gupta. Preeya is a professor of ophthalmology at the UK University in Durham, North Carolina, United States. So, Maurizio, I would like to start with you. You have a broad experience in treating patients with dry eye, but also a lot of experience in the field of research of dry eye. So, Maurizio, you are the right person to answer this question. What is dry eye?
Well, I really don't know, but I'm trying. It's 30 years that I'm working, trying to discover what it is behind what we call dry eye. And I must say at the beginning, I was working in Boston with Klaus Dolman, and we used to have a patient with dry eye, but usually they are Sjögren's syndromes. And once Klaus told me, well, we were talking about evaporation, and Klaus told me, why don't you study the evaporation from the ocular surface? Klaus was studying the transportation of the water across the cornea, and told me, well, why don't we study? And as a matter of fact, I noticed that a lot of dry eyes, they do have an increased tear evaporation. And this was very characteristics of people that we thought they had some kind of inflammation on the surface. And they also complained there were symptoms of dry eye, but they have a higher Schirmer test. And so by chance, I invented what is called evaporative dry eye now. And then slowly things changed, because we started to understand that it was not just a pure problem of lack of tears, but the composition of the tears was changing. And we came out with the term toxic tears, again, many years ago. So telling that the tears can become toxic for the ocular surface. And this was another step in understanding what's going on. And then we see that there are different patients at different characteristics. So not just the pure, lack of tears, a very thin meniscus and so on, but you have an inflamed surface. And then I think this was the real turning point of the understanding what's going on and understanding the possible approach to the therapy of dry eyes. And so understanding that it's not just a problem of lack of tears, that's a name, dry eye, which is wrong, of course, because most of the patient, they don't have a dry surface, but we have, the combination of the two things. And then the evolution started to see that there is involvement also, not just of the tears, but also the epithelia and the lids and so on. And then we started for, a problem of having little tears on the surface. Then into slowly shifting into a disease. It's not just a symptom, a collection of symptoms or signs, but a real disease. I don't know if I answered your question, but this is...
Yes, it's clear. So now we're talking about a dry eye disease. I totally agree with you, Maurizio. We are not talking about dry eye syndrome anymore, but we are talking about dry eye disease. Very, very important. At the same time, it's very important for our patients. Preeya, who are the patients with dry eye? I mean, what do they complain about, and what is their quality of life?
Well, this is such an important topic because I think it's important for clinicians to realize that not all dry eye disease patients look alike, and nor do they complain of the same things. So one person might come in with what we call classic symptoms of redness, irritation, foreign body sensation, while the next person might come in with fluctuating vision, blurry vision, and they don't identify, necessarily with pain or discomfort. And so as clinicians, we have to have a high threshold to be looking for these patients, whether it's in our, general routine population or in our cataract and refractive population, and really, have a high suspicion for dry eye when patients complain of that, classic symptom, but also when they complain of non-classical symptoms like fluctuating vision.
Does it happen to you to see patients that complain a lot about the symptoms, but then you look at the surface of the eye and you don't see many signs? And also the opposite situations, like patients with no signs, but complaining a lot. Does it happen to you?
Oh, all the time. I think that what happens over time in dry eye, in the early stages, patients tend to be very symptomatic, and often their ocular surface can still kind of hold it together to maintain some level of homeostasis, such that you're not necessarily going to see breakdown of the epithelium or conjunctival staining of the cornea or the conjunctiva. And so those are the patients where you look in and say, you look like you should be fine. Why are you complaining so much? And unfortunately, over time, what happens is that these patients become almost, neurotrophic like. Their bodies become used to that chronic signal of pain, discomfort. And unfortunately, with repeated sort of cycles of inflammation, patients will have compromise of the ocular surface. And it's almost, if you think about it like a protective mechanism, the body tries to stop sending that signal to the brain to say, hey, there's something wrong. There's something wrong with your ocular surface. And so sometimes our more severe patients actually don't have as many complaints as our mild early patients.
So Maurizio, it seems to be that there is a sort of like a vicious cycle that determines dry eye, and the patients can stay into the cycle, come out from this cycle, but everything starts from an alteration of the ocular surface system. Can you please describe to us what is this ocular surface system and how does it work? I know that you have published recently a paper about a new classification of dry eye. Can you please tell us something more about this point?
Well, yeah, as you said, the patient with the starting to have this problem with so-said dryness or these symptoms, they do enter into a vicious circle, which is bringing more and more as far as pathologies to the ocular surface. The ocular surface is really a system. It's a system involving the tear film, the epithelia, the lacrimal glands, and the lids, the movement, the muscles of the lids, the outflow pathways of the tears into the nose, and of course the conjunctiva and so on. So it's a real system which is able to react. And this is what is called hormesis, the ability to react and to maintain the homeostasis. If something comes out from outside, like wind, a lot of wind, working with a computer, or something coming from inside, like a disease, will change our ability to react, and the patient can enter into a vicious circle, which is going to maintain. Sometimes you don't find the starting point that brought the patient into the vicious circle. It's very common after, viral conjunctivitis, which is inflammation lasting quite longer on the surface. Then the patient starts complaining. Well, then it's perfectly healed by far from the point of view of the conjunctivitis, but the patient still complains of dryness on the surface. So something happened to the system, and the system is not able to cope with the stimuli coming from the outside. And they get involved in this vicious circle, which is sometimes is a spiral that they're getting worse and worse. Some patients can stay into the vicious circle for a while and then can get off. Let's see, some patients get, anytime I work with the computer, I feel my eyes burning. And sometimes this burning goes away, sometimes not. In the weekend goes away. So they still are able to compensate. But a number of other patients, the disease become persistent. And this patient, they enter in the vicious circle. In the vicious circle, it's always it's the presence of a tear film instability, is the presence of some kind of inflammation that you can see, or maybe you cannot see, that they call what we call para-inflammation, and then you have a malfunction of the epithelia or damage to the epithelia. So sometimes the epithelia will stain, but sometimes it's not staining, but it's not producing the glycoproteins of the mucins. So the epithelia is not working perfectly. And then you can have, as a result of this vicious cycle in the 3 points, you can have, as a result or as a starting point, troubles in the functioning of the nerves, as has been said before, or you can have troubles in the functioning and the secretion of the meibomian glands and of the lids. So you have these 5 points, which are really the points that you have to use to make the assessment of your diagnosis. How much epithelial defect do I have? How much instability? How are the lids? How are the nerves? And these are also the things that we can treat. We can treat the stability of the film, we can treat inflammation, we can protect the epithelium, and so on. So the starting to think that dry eye is not a problem of tears, but dry eye disease is a problem of the ocular surface system, will change our approach to the disease. Hopefully also, we can do something better for our patients, which are not very happy of us. I mean, they're always complaining.
And this is very important, and it's very practical. I mean, your message. I mean, when you see a patient at a slit lamp, and patients are complaining about symptoms that can refer to a problem with the ocular surface. If you see your patient at a slit lamp and then you think about the ocular surface as a system, in most of the cases, you can make the correct diagnosis. Otherwise, you can miss something. For example, if you had corneal defects in the inferior part and you think as a corneal problem, you may you may miss the diagnosis, because the problem in this patient could be an alteration of the margin, as Maurizio has just said. So again, it's a very practical method. Look at the slit lamp and think about the ocular surface as a system. Preeya, surgery and dry eye. Can be surgery one of the main reasons for dry eye? We know a lot about refractive surgery, but we are now aware that also cataract surgery can induce dry eye. Can you please tell us something more about this aspect?
Absolutely. Cataract surgery is probably one of the most common ophthalmic surgeries that's done. And I think for all of us that do cataract surgery, we've had a patient come in with 20/20 vision on the chart, but is miserable. Their eye might hurt, might be uncomfortable. But more importantly, they come in and complain that they can't see. And it's very puzzling. And more often than not, that is a patient that has dry eye or MGD that has been, that was compensated prior to surgery, that then becomes, decompensated after surgery. And so, it only takes one or two of those patients to realize the importance of recognizing and diagnosing and treating dry eye disease before cataract or refractive surgery. And Dr. Christar from Cornell and I published a study, I guess it's 2 years ago now, when time is flying by. But we asked ourselves this very question: well, how often is it that someone's coming in with dry-eyed at the time of cataract evaluation? And what we found was almost 80% of patients presenting to our office for cataract evaluation have ocular surface disease. And so what we did was we gave patients a questionnaire. We also did MMP9 and osmolarity testing and a clinical exam. And, it really was astounding to see that overwhelmingly the vast majority of patients that come to our clinic have ocular surface disease. And especially in this era of modern technology, we have trifocal lenses, we have femtosecond laser, we have all these tools and all these ways to deliver excellent visual outcomes. But if we're not treating ocular surface disease, we can't really harness and leverage those premium technologies to give patients the vision that they want. And, frankly, I think even in our, patients that are getting monofocal lenses, they want to see well too. And the tear film is very much responsible for the quality of vision. And another interesting aspect of our study is that, so about half of the patients in the study scored positively or had an elevated score on the questionnaire, but about half were not positive, meaning they had no symptoms. And in those patients, 75% or so of them had abnormal tear film testing. And so those are the patients, that when we see in clinic, the ones that are doing just fine, I never had this problem, your surgery created this problem for me. Those are the patients that we need to identify. And the study really nicely showed that about half of our patients are asymptomatic who actually have the disease. So, just food for thought for everyone out there. But I think that this is a very important topic as it relates to our surgical outcomes.
We'll have some more opportunities to talk about treatment. But in this case, for example, would you recommend to use substitute tears after cataract surgery?
In somebody that has, like, for example, dry eye that was identified before, I think artificial tears are great for supplementation. And of course, it's something that patients are very comfortable with. They understand what a tear is. But I think in this pre-surgical population, at least in my own clinical practice, I tend to be a little bit more aggressive in those patients and start them on, different therapies depending on, as Maurizio pointed out, the different types of dry eye disease that are out there. So trying to tailor their therapy to what I'm seeing clinically. And the reason I think why it's important to be a little more aggressive is that some of these therapies like artificial tears can be a good supportive treatment. And yeah, to answer your question, yes, I do recommend those patients to use them after surgery, but sometimes it's not enough to really prepare them to be, so to speak, treated prior to surgery.
This is a very important point. I completely agree with you. You have to be very careful before the surgery. Great point. Maurizio, we are seeing more and more young patients complaining about a dry eye symptom. I mean, what's going on?
Yeah, it's going on with that boys are using telephones and retro-illuminated screens by 6, 7 hours a day at least. So if you look at a retro-illuminated screen, and there are two things that happens. You blink less frequently, I mean, and you blink incomplete. And both these things can enhance the time that the ocular surface is exposed to evaporation. And so there is an increased dryness. But also, it's very important the frequency and the completeness of the blink, because whenever you blink, you push, you make a compression on the meibomian glands, and you stimulate the production of the lipids. And if you don't blink, your lipids will stay or in the reservoir of the lids or inside the gland. And these lipids are becoming oxidated by the pollution, by just being exposed to the air, and they change their performance. So you see a more rigid lipid layer, and sometimes the lipid layer has holes in the surface, because if it's oxidated, they change it. There's this kind of retraction of the molecules, so you have increased permeability to the vapor. So this happens. This is the main reason. You don't blink enough, you're not going to have a good lipid film on the surface of the eye. So you get what we call evaporative dry eye. And this is what happens. And then it starts inflammation. And then from inflammation, you enter the vicious circle. If you don't have the ability to come out from the vicious circle, you get a real disease. I mean, a lasting disease. Don't forget to blink. Don't forget to have a rest while you working on the computer. There is a law 6 and 6, so have a few minutes, then you stop, and it's, I think in the United States it's 20, 20, 20, and so 20 minutes, 20 seconds, stop and look 20 yards away when you want to relax the eyes. But don't forget to blink.
Yes, it's a good recommendation. And yes, because smart working and e-learning, unfortunately, they induce dry eye because we stay a lot of hours in front of a screen. So thank you very much, Maurizio and Preeya. We'll also have a look at the diagnosis and treatment in the next meetings. So thank you very much for staying with us, and thank you very much for giving all these nice points of view and suggestions on how to manage our patients to dry, starting from understanding what a dry eye really is. Thank you very much.